Yes, I can hear you. You will hear us.
Good morning, my brother.
Good morning. How are you today?
Sorry, it's only today we disturb your sleep. After today, you will enjoy your sleep for the rest of Ramadan.
Don't worry. It's okay.
So in another 10 minutes, we start.
No problem.
Good
morning. Yes,
Good morning, my village.
Good morning. How are you?
I'm greeting you.
How are
Fine,
you
sir.
today?
I'm fine, sir.
It's been a long time.
Yes.
Now, we take SIMs on nowadays. So
I'm living in a difficult area.
Well, no area is difficult anymore. Once you get out and get in early enough.
Yeah, that's a trick.
For every minute that you guys are late, I'm going to charge
don't worry.
$1,000.
Don't worry, I will pay. Don't worry.
Okay. That's a promise. So
Yeah.
it's in Ramadan.
Yeah, don't worry. If I can't pay, we have supporters who's around here.
Okay, that's good. That's good.
You understand my situation.
You know, we are not used to timekeeping. That's
Yeah.
us.
This start program.
Now I will start. Okay, maybe because I didn't include the line.
Okay.
Yes, this meeting is rather too early.
Don't worry. It's only for serious-minded people.
Okay. All right.
It's not what to do.
I said,
I want to look at making code. But I like to have this backup. If it doesn't work,
Would you be able to share it?
you can share.
it's a negative person. So
I don't like it.
it's quite
Right.
up there with my making quotes. So, my brother, you've been made a co-host.
Okay.
Hello. So if there's any issue, have a backup here.
Yeah, it's okay. It's a co-host. I can let me just try. I see. Check my.
Good morning, Tosi.
Okay, it's fine.
Good morning.
Okay, thank you.
Good morning, sir.
How are you?
Not bad, sir. Good morning, sir. Well done, sir.
Thank you. Thank you for coming so early. In another 5 minutes, we start.
Thank you so much, sir. Yes, sir.
I think you should make it 10 minutes so at least you have 10 people.
Yes, so good morning, my PDG.
Good morning.
Thank you.
I do pesa.
How are you? How's my brother?
It's fine. Doing well. We thank God, sir.
Oh, thank God. Thank God.
Yes, sir.
I know I know to be.
Uzamaka, good morning.
Good morning, my PDG.
How are you?
Good morning.
I'm fine, thank you. Good morning.
How are you?
You are part of my underwriters. Okay. Thank you.
Yes, thank you. Good morning, my PDG. Good morning. How are you?
Good morning. How are you?
I'm fine, thank you.
It's your sister greeting you, so another way of greeting you here.
Okay. Which was
Okay. Let us see.
Okay.
Good morning.
Good morning, sir.
Good morning.
Now,
now that my thing is done, in another
Hello? Okay, nǹkan tó lọ ṣe nìyẹn. Pẹ̀lẹ́. Ó ti délé àbọ̀.
Mama Agbe Davis. We are hearing your voice, so. My PhD user.
Good morning, my PhD.
Yes, sir. Good morning, sir. My PhD, sir.
Good morning, my own IMD. Now.
With the peace activator trainers training team.
Don't worry, we just take your 10 minutes, then you can concentrate over there. We start in another.
Are they starting so early?
Good morning, sir.
Good morning.
Yes, sir. The question, how's yonder?
Yonder is good, though. Yonder is good. Yonder is cold sometimes.
Very obvious. Yes, sir. I could do that. Mommy, come.
And mommy came to Lagos. He's back in Lagos.
Okay.
Don't worry, it will be with you in another 2.
He's came to Lagos.
Yes, sir.
Okay, so we start.
How many are we now? 12.
Don't worry. No, 2 more minutes. Even your brother is even arriving here. Your mate is arriving. Your mate is OTG.
OTG. That's good. He was complaining about time too early.
Don't worry. We summon him. I felt it. If 2 a.m. is not too early for some people, nobody can complain about it. So. Don't worry. After this, go back.
Sir.
My DG.
Sir. Yes, sir.
How are you?
Sir.
Francis ńkọ́?
Ó wà sà. Yes sir.
Kẹ́ ń gbúrò lọ́tún lọ́sì.
Adúpẹ́ sà, ẹ̀yin náà ńkọ́ sà.
Gbúrò.
Mọ́mì ńkọ́?
Yeah.
Maybe I
Yọ̀mí
should
ṣe bó sọ fún àlejò. Mo ní ṣe bó sọ fún àlejò.
Kàmọ́rù náà ló convince mi pé mo gbọ́dọ̀ wá.
You know, Kamaru, you can't say no to him.
I can't.
Ìjẹ̀ṣà ọmọ Ìjẹ̀ṣà máa ń jẹ́ àgbo àti àgbo mi lónìí.
For possible, that's what if not for him. I was my Nigeria argument. Look very fine. So, it doesn't need so not to keep in tune with the program, we start now, please. The rest will be meeting us on the way. So those who want to go to bed in time, I promise them a particular time. I don't want to exceed that time. So, good morning, my imaginative district governor.
Good morning, sir.
Fellow imaginative Rotarians, good morning. Good morning. Especially those in diaspora, by one of our facilitators, PDP, Adenike Raji. Thank you very much for joining us at this inconvenient time for your time zone. We really appreciate it. Thank you. Fellow imaginative Rotarians, welcome to a fresh edition of our strategic training action in Rotary. In April, when we are discussing maternal and child health. At a recent WHO report, 5.2 million children under the age of 5 worldwide are lost to preventable and treatable causes. Equally true, 240 million women of childbearing age have unmet needs of modern contraceptive with unacceptable death rates from complications of pregnancy and childbearing. In this month, we need to find out what are the Rotary doing about it and what we should get involved in doing. This morning, we have 3 eminent facilitators. First Assistant Governor Ogbazi will be talking to us about overview generally of what we do, how we get involved, and what Rotary should be doing. While telling us what we need to do, First District Governor Raji will actually tell us the success story of what has been done in our own district 9110. And our Professor, First District Governor Yomi Adewumi, will be telling us in practical details what we'll be doing. But before we go into the business, I'll call my ever busy achiever, imaginative district governor to welcome you all to this program. My DG, over to you, please. Thank you.
District trainer, my own district governor, past district governor, Kamaru Omotosho. Good morning, sir. I acknowledge you. Thank you, sir. Past district governor, Adenike Raji from diaspora. I really appreciate you having to tune in as early as this. Past district governor, let me borrow the word of my PDG, Professor Abayomi Adewumi. I welcome you this morning. And of course, my darling sister, PAG Uzo Ugwazi. Nice to see you this morning. Fellow Rotarians online, all imaginative Rotarians, presidents, assistant governors, past assistant governors, all those who are joining us either from many parts of the world. I welcome you all to this edition, the April edition, and I want to say that I'm singularly happy to declare or to call this meeting to order while we take the Rotary grace. After the count of 3, 1, 2, 3. Oh Lord, giver of all, we praise thee for Adeyo. May Rotary praise and Rotary ways help us to keep all our days. Of course, it's normal that we'll all start at different times and we're going to end at different times because we are different locations. Thank you very much.
Thank you very much, Mike. So you are now free to go and join your major assignment for today.
Yes, sir. Let me just give you maybe a short remark, sir. Particularly because this is month of maternal and child health. I want to welcome our gurus in the house. There's nothing much I will say that they don't have loaded with. But let me just quickly say that this month is so symbolic because this is the month that we are expecting our partners in medical mission, the Association of European Physicians in the Americas, and this is the month that we're looking forward to. And incidentally, there was this project, the goal I had from the beginning of the Rotary year to carry out fibrous studies on women, about 200. At that time, I tried to see how this could be done. And I couldn't see any way out. But as God will have it, we have these people, this body, seeking to partner with us. And so that goal will be achieved. And that my prayer will be answered. But what is most particularly symbolic is the fact that it's happening in the month of maternal and child health. And part of what they are coming to do, which is even more interesting than surgeries or any other kind of intervention, they're going to train doctors, they're going to train midwives, they're going to train nurses. But in one area that I think I'm excited about, and that is help babies breathe. Help babies breathe. Because we have lost quite a large number of kids who died at childbirth because the proper strategy to use as at the time when they are struggling to breathe, we're not able to employ the strategies. So by the time they're done, those that they would have trained will now train many others. I'm saying that train the trainers. So I'm excited about that. That's why I said it's just so coincidental that they are coming. And this month will not go without having more knowledge added to the knowledge of our medical team. So on that note, I want to say thank you very much, everybody, and welcome on board again.
Thank you very much. Thank you. Now that my DG has already addressed us, again, that keeps saying this is a woman's word. Let PAG Obuazi take over and tell us the overview as members of the District Committee about what to expect on maternal and child health podium. Thank you very much.
Good morning. I recognize the teaching of past governors, our fellow Rotarians. First month we are talking about maternal and child health. And again, one of those topics in one of those areas in Rotary where Rotary has shown a lot of support, and where Rotary support is needed a lot more than we can do. So I'll just go quickly into what we have come here today to look at, and that is what are the Rotary's goals for maternal and child health. So Rotary supports activities and training that improve maternal health and reduce mortality for children under age 5. Our projects improve access to care, expand medical services, provide medical equipment, and train healthcare providers. We can improve the health of mothers and their children by one, reducing the neonatal and newborn mortality rate. That's what the DG has just talked about a few minutes ago, that the medical team that is coming is going to address that. It's quite a high rate of that. Reducing the mortality and morbidity rate of children under 5, reducing the maternal mortality and morbidity rate. Again, we still have a lot of mothers dying at childbirth, and that is something that we can address and we can improve on. Improving access to essential medical services, trained community health workers and healthcare providers, funding graduate scholarships for career-minded professionals related to maternal and child health. These are some of the areas where Rotary has tried to work on maternal and child health. And so we go on to what we call the community assessment for maternal and child health. For us, Rotarians, we know that we can't do any project without doing the basic community assessment. So how do we do this? Community assessment identify where our support is needed, and the role Rotary members can have in making a difference. An assessment will illustrate the community's strengths and weaknesses and help you work with local residents in solutions. Projects sponsors, often in conjunction with the cooperating organization, need to conduct a community assessment before applying for a grant. Suppose some of the projects can be done through an application of a grant, or even without a grant, you still need to do this assessment. If an assessment has already been done, use the relevant data to design your project. So we go to the next one, and it is use the community assessments to gather perspectives from the broad cross-section of the community, including women, young people, and professionals. Allow community members to identify the needs that they perceive as the most critical, because sometimes we don't realize that something as simple as breastfeeding or is more critical to the community than one of the other things that we might want to do. Ask community participants how they can be involved in the proposed project. It's always good when we're doing this kind of projects to make sure that the community is part of the project, and and then they so that you have a role to play. Work with community members to identify long-term goals and expected project outcomes. Gather baseline data before the project so you can measure your results. The community assessment results need to be incorporated into your project plan. The results should describe how the project aims will be met. That is cool. So what types of projects and activities are eligible? What kind of projects and activities can we do? The foundation considers the following activities to be within the scope of maternal and child health, reducing the morbidity and mortality rates among newborns, children under 5, mothers and women of childbearing age, improving access to high quality health care. Your specific project might provide we got it? Sustainability. I think you're going to go for it. So how do we make our projects? We have talked about sustainability, means providing long-term solutions to community needs. That local residents can maintain after the grant funding ends. These solutions need to be relevant to the community and sensitive to cultural and environmental factors. Pay careful attention to the following items to ensure your project's long-term sustainability. So, what are the clear plans for sustainability? Involve community members when you select technology equipment. Sometimes we select equipment that cannot be managed by the community or by the people that are giving it. There are equipment that have been donated that have not been able to, that the community couldn't use. And train them on how to operate, maintain, and repair it on their own. Involve all stakeholders, not just the local elite, but the actual users of people who will benefit in all aspects of the project implementation, including site selection, training, and maintenance. Purchase equipment and new technology from local sources when possible, and make sure that replacement parts are readily available. The grant application, if you apply for a grant, should describe the equipment being purchased or donated, and the plan for training people to operate it. Explain why for any equipment that is not being purchased locally, and provide plans for training, operation, and maintenance in the community, including how replacement parts will be obtained. Describe the physical environment where the equipment or technology is to be kept. Identify who owns it and provide security protocols. Explain how this equipment or technology is essential or related to the project's objective. Include a long-term financial plan for updating any software you need to purchase. We have had equipment that have been purchased and given to some healthcare centers that have not been able to work with it. I remember we had to move a donation that we made to a healthcare center to another healthcare center because we discovered that the one that we gave the healthcare center didn't have a particular need for it or didn't know how to use it. So we have to ensure that these things are taken care of. So for us to succeed in any project, we have to think about financial planning. Ensure that your project will have sustainable funding from local organizations, residents, or the government to integrate the project into the community and support its long-term success. Confirm that local funding sources are available to pay for long-term operational costs. Discover that when you're dealing with healthcare, we work with one of the health care in Lagos, that it has to be long-term, and then you have to make sure that it is regularly funded. So sometimes you have to really make sure that you partner with people who can maybe every year make a donation and enable the project to go on. Maintenance, training, replacement equipment for updated technology. Compensate project participants appropriately for their work to ensure continued service. Please, if you pick anybody to work with you on a project like this, ensure that they are paid their due costs so that you don't have people sabotaging the project after. So what kinds of projects and activities are eligible for global grants or generally for maternal and health, child health? So the foundation for this considers the following activities to be within the scope of maternal and child health. Reducing the morbidity and mortality rates among newborns, children under 5, mothers and women of childbearing age, improving access to higher quality health care. Your specific project might provide maternal, prenatal, delivery, and postpartum care. Now, we discover that in this country, people really don't care too much after delivery, and so we need to find out what happens. How are these children going to be, these women, what they go through? We know that some women get into depression through this after their childbirth. We don't really take care of that so much in this country. And it's something that we have to start thinking about, and it's something that we can maybe train a professional in some of the health centers so that the women can come there and be able to talk to them and be able to walk through with them. So we have more project ideas. One of them is training. You discover that all through this, we'll talk about training with health care, and anytime you're working with the health professionals, you must make provision for training. Now you can train the trainer. Training the trainer means that we don't have to constantly bring professionals to come and train them. You can have people locally who can be trained so that they can train other people. Training initiatives for maternal and child health care workers at the professional and community level, including doctors, nurses, midwives, and traditional and skilled birth attendants. We discover that there are still areas where people use the traditional skilled birth attendant. So then you have medical equipment for healthcare facilities. If the project includes educational activities for women related to having healthy pregnancies and deliveries or neonatal care, then you have to make sure that those things are done. Education about and improved access to family planning services and other sexual and reproductive health. This I particularly want to emphasize on because it's like we are not selling the idea of family planning enough. People still don't have an appreciation of the fact that if you don't plan how many children you can manage, at the end of the day, you're just going to produce people who are going to, in future, maybe be a problem to the community. So we have to find a way of going to the community and explaining to children, to women the need for family planning. And then, of course, we have all the other sexual and the reproductive health, which again we need to, some of these things require maybe having seminars or having talks with the community where they can do this. And then we have the next one is immunization for women, adolescent girls and children under 5 to end vaccine preventable illnesses. There are so many illnesses that we can prevent from giving a vaccine. Rotary have worked so hard with polio, but there are so many other things that we can work with, and we can do, encourage mothers and girls, mothers to take their children for the vaccine, and then the young girls where they need to have the vaccines for them to can have the vaccine. So interventions to combat pneumonia, diarrhea, malaria, measles, and other major causes of disease in women and children under 5. We discovered that things like diarrhea has to do with the, we have just finished doing the watch and the water sanitation and hygiene. So last month, so this month we're talking about this, and diarrhea is one of the benefits of having clean water. And then maybe there will be need for provision of clean water in some of the areas. What most clubs do is do boreholes. We have to, when we're doing the boreholes, put treatment so that the water will really be clean. We have to clean our waters to get malaria off. And then other major causes of disease in women and in children under 5. So strategies or training to promote breastfeeding and other actions that prevent, reduce, and treat the effects of malnutrition. I know that there's a kind of encouraging, what do they call it, the women breastfeeding all the time, not giving formula. And you discover that most of the working women, sometimes it's difficult for them to achieve that, but it's something that we have to discuss and then find a way of helping them to achieve this. Thank you very much.
Thank you very much, Uche. Thank you for keeping within the limits of the time. Now, she has given most of the theoretical aspect of what you are expected to do. As we do in this program, we now give you the practical details so that you don't just think it's just theoretical that may be too complicated for you to see. As a sort of a guide, this program presentation will still be on the top trainers platform for you to do and to read at your own convenience. I will now call on Past District Governor Adeniji Raji, who will tell you exactly what has been done in our own district. Thereafter, our brother here, Yomi Adewumi, will tell you the practical details after the Adeniji Raji. My brother, over to you. Tell us what has the success story of what has been done in District 9110.
Thank you very much. District Governor in absentia, the district trainer, fellow Rotarians. Before I put on my slides, I'd like to read a short message about mothers. They say mother is the pillar of strength in everyone's life. She is the one without whom our life is incomplete. And in spite of all this, today, 82,000 women die of preventable diseases in Nigeria. So that calls for deep thinking and activity. Let me go to my slide. Right, as you know, today, this month is Rotary area of focus, maternal and child health. And our objective is to make Rotary to make high quality healthcare available to vulnerable mothers and children so they can stay alive and live longer and grow stronger. That's the objective. In the next few minutes, I'll be telling you, because there's no point trying to find cures, but you must know what are the causes of maternal deaths and perinatal deaths. So in the next few minutes, I'll be telling you what are the causes of maternal deaths and what can Rotary do. And also, I will give you the statistics of what the statistics of maternal deaths in Africa. And you can see where Nigeria stands. So, what is the goal? What is the goal of the maternal and child health? The goal is to substantially reduce maternal and child mortality and morbidity. When I show you the statistics, we then can know that we in Nigeria, we are still on the high side. Also, we are supposed to improve the quality of infrastructure hygiene in health facilities. Many of you will know that some primary health centers, which are close to the people, don't have sufficient facilities to deal with mothers and children. When we were in Ibadan, sometimes Ibadan West, they said the primary health center closes at 6, and when it's not closing, there's no generator. So the primary health center is not actually addressing the needs of the people. Thirdly, we are improving the quality of healthcare provided. If you have good facilities in hospitals, in primary health centers, in tertiary institutions for mothers, then we have the healthcare facility improved. And then if those 3 items we have mentioned, if we can do them, then obviously the quality of the outcomes of mothers and babies will improve. Then we will have more women surviving, more children surviving, and our maternal death ratio will go down. All right, there are 4 risky and life-threatening pregnancies, which we must know. 1, too early. When a girl is 12, 11, and it gets pregnant, it's too early. It's likely to have the VVF, vestibulovaginal fistula, which is a condition where the bladder and the vagina are linked together, and then it becomes the urine comes through the vagina all the time and is inconsistent. So it is important that children that not of age should not be pregnant. So one of the bad threatening pregnancies is too early. That is, it has 12, 15. In fact, it's best for a child to have a child maybe at 21. But if it's too early, it has complications. Too late, when you are over 50, in fact, doctors now say that it is safer for women to have their children by the age 35, but still they stretch it to maybe 51. Even that is too late. That is also a very risky pregnancy. Too close. If it's too close, you have one this year, you have one next year, you have one next year, then it's too close, and then you are putting yourself in a lot of problems. So those are very risky pregnancies where you continuously have children almost every year. When we get to community dialogue, we will see where we advocate, advocate child spacing, in which case, if you have one this year, it is better for you to have another one 2 or 3 years after. So those are very risky pregnancies when it's too close. And too many. When it's too many, you also exposing yourselves to danger. I don't know whether many of you have seen the video why Mrs. X died, but you can Google it and watch that video why Mrs. X died. Some of these issues are raised in that video. Then there are 3 delays. What are these 3 delays? When a woman is trying to have a baby, sometimes people fabricate or hesitate to take the pregnant woman to the hospital, and therefore it might start bleeding or any eventuality can happen. And this is where our traditional birth attendants comes into play, because 50% of childbirth in Nigeria still today it comes from traditional birth attendants, people who do the delivery at home. So sometimes when it's beyond her, she won't take her to the hospital, and that may cause a lot of problem. If that decision is not taken in time, there might be problem. Of course, we also know transportation. Even in Lagos, you can be in the traffic for hours. So that's also a delay that can cause maternal death or even perinatal death. Even at the health facility, if there is no bed space or there's no skilled worker, there's no trained midwife to actually deliver the baby, or if it requires a cesarean operation and the hospital is not geared to have cesarean operation, maybe the anesthetics is not there, maybe they don't have the blood, maybe they don't have the oxygen. So you find these are problems that can arise from these 3 delays. Yes, I show here the burden of maternal deaths in Africa. You can see Sierra Leone has the highest number of maternal deaths in Africa. That is, it has 1,360 maternal deaths out of 100,000 live births. That is, when you have 100,000 births, 1,360 of them will die, which is very sad. And you see our own country, we have 512 maternal deaths per 100,000 live births. During our last project, I think my colleague Yami will talk about it. We tried to bring this number down to 400. We are still to know whether we are able to reach that milestone. But you can see Egypt. Egypt has 37 maternal deaths out of 100,000 live births. So we still have a long way to go because 512 people dying, mothers dying out of 100,000 live births is not good enough. What are the leading causes of maternal deaths? I think we need to know. Obstetric hemorrhage is simply bleeding, either pre or postpartum bleeding. When a woman has had a baby, sometimes they bleed beyond what is required. The doctors know what to do, but generally it has many causes. Some the child is either too big and coming through the canal. Sometimes the woman will have a tear and will start to bleed. And sometimes the bleeding does not coagulate, does not clot. So it continues to bleed. But usually the doctors are quite aware of what needs to be done. But obstetric hemorrhage is one of the main causes of maternal death in women. The other one is eclampsia. Eclampsia is a serious condition, and it stems from what we call pre-eclampsia, which is sometimes a woman will have urine, will have protein in her urine, and her blood pressure will be high. And that points to the need for women who are pregnant to do antenatal care. Because if you had gone for antenatal care, the doctors will have found out that he has a pre-eclampsia, that is, he has urine, he has protein in urine, and their blood pressure is high. And if it goes to septic stomach, it could lead to damage to internal organs like the kidney, the liver, and it could lead to death. But the earlier the doctor finds out that the pregnant woman has preeclampsia, they will treat it and is likely to survive. But that's one of the problems. The other one is sepsis, which is having a disease or an infection. If the infection goes to become septic, it could affect his lungs, his kidneys, and it could lead to death. But usually, when women go for antenatal clinic, most of these conditionalities are discovered and they are remedied. But these are one of the problems that women are likely to have. Complications of labor and delivery. Well, that has several aspects. Sometimes the baby is too big and it cannot come through the canal, and it may need to do a cesarean operation, or sometimes it may also become, may have hemorrhage, may have bleeding. And so those are part of the complications of delivery. Sometimes the head will come out and the arm will get stuck in the canal, and it could take a little while before they could really entangle it, or it may have to do a cesarean operation. And the last one is complications of unsafe abortions. Unsafe abortion is defined by WHO as an abortion, a procedure which has been done by a non-qualified person. I mean, in our society, we have a lot of pharmacies and all sorts of people who will give young girls some medication, just go and take it, or some will drink a lot of alcohol to get rid of the pregnancies. Some of those are unsafe abortion. And also, WHO describes unsafe abortion as if it's done on unclassified medical outreach. If it's not a place where doctors who know what to do carry out the abortion. But it must be also known that 97% of unsafe abortions happen in Africa, in Latin America, South and Western Asia. But the problem with unsafe abortion, the complication arising from unsafe abortion is that around the world, over 7 million women have complications due to unsafe abortion.
Being away, I would have told them that, okay, you have 7 weeks, 5 weeks.
Yes, let's go to what can Rotarians do? First and foremost, I will ask Rotarians to join Rotary Action Group for Reproductive, Maternal and Child Health. Unfortunately, our DG is not here. Our DG is the current membership chair for Southwest, and is also our zonal coordinator. And RMCH, Rotary Action Group for Reproductive Maternal Health, is registered in Nigeria now, so that we, as RMCH, can also assist clubs to get global grants or other grants to help save mothers and children. 2, we do advocacy, in which case we talk to stakeholders, government, traditional leaders, and community influencers to sustain the efforts to accelerate reduction of maternal and neonatal mortality through 1, improved budget allocations. During our last project, we found that some of the state governments were not budgeting for the HMIS. We will be able to give money to those who will take record of mothers, so that we were able to persuade them to start putting budgets through for such activities. But most importantly is the upgrading of health centers. I said earlier on, in Ibadan, there was a health center where they closed at 6, no generator. Maybe there will be no qualified midwife, so that if a woman who is pregnant and is wants to have the baby gets to such a center, it will not have service. So it is important to upgrade all the health centers. I know in Ogun State, they bought so that when a woman is going to have a baby, you can call a number, the Kekemarua will take her to an appropriate health center. So that's one way that we Rotarians can help to improve maternal and child health. So that's one location. The other is community dialogues. We need to create public awareness. We normally have stakeholders from the ballet to the Okada rider to traditional birth attendants, nurses, and all strata of society to attend the community dialogue. And at the community dialogue, we talk to them about shared spacing. I've told you one of the problems is when somebody has the children too close. So we talk to them about child spacing and antenatal attendance. I mean, if somebody who is who has preeclampsia, that is has protein in her blood, in her urine, or his blood pressure is high, if it goes to antenatal attendance, it will be corrected and it will be saved. Facility deliveries under key supervision. That's also key because right now, as I said earlier, 50% of deliveries are done by traditional birth attendants. Many of the states like Lagos, Ogun, they are training their traditional birth attendants. And in fact, in those states, when a traditional birth attendant, when he knows he can't handle it and brings it to the facility, brings to the hospital, he gets a stipend because it's a loss of income to her for bringing the patient. So it is important that we have more deliveries within the facility, within hospitals, rather than traditional birth attendants. Also, we need to eliminate the 3 delays, which is hesitancy to go to the hospital or this distance to the hospital. You have to find a way to get to the hospital, and also to have proper staff at the hospitals so that they can be delivered. And if the woman needs a cesarean operation, all the required personnel are there. The anesthesia, the doctor, the oxygen, the blood, just in case you would need those things. So those are the 3 delays. And of course, we talked about the elimination of the risky pregnancies, too early, too close, too soon, and too late. Those 3, if you can eliminate it. But those are, you can always talk to people about what they need to do. Well, many husbands really don't want their wives to do what do you call it? It escaped me, to have pardon me, if a woman to go for I forget it, to do can somebody remind me, to do contraceptive
family
yes.
plan.
to have contraceptive, because some husbands think that if their wives have contraceptive, is a way of messing around. So it's contraceptive is also key. But today there are a lot of many reversible contraceptives. You can decide 5 years you are not going to have a baby, and after 5 years you can remove the contraceptive and you are good to go. Well, Uzos talked about capacity building. That is key. In our last project, we trained doctors, nurses, midwives, and on long-acting reversible contraceptives, which is good for most women who decide, yes, I've had 2 kids, but the next 5 years, I don't want to have kids. They can have reversible contraceptive. Well, training of medical record officers. When I go to the next one, you see the need for these medical record officers, because they are the ones who record deaths in hospitals, and with their phones, they can transmit the data to either the HMIs in the state or to the state's data bank, and straight to also to the Federal Ministry of Health in Abuja. And the beauty of it is that that data can be retrieved by the HMIs or by the Commissioner for Health to know what is going on in the hospital. And that goes for the training of health management information officers, because she's in charge of all the medical record officers, and they are accountable to her. Local government's monitoring and evaluation. As I said earlier on, 50% of births and sometimes deaths happen in communities where there are no hospitals. So the local government monitoring and evaluation officers are located in local government areas, and they go and do what we call autopsies that they can then record to into the platform. But they also have access to the NOQA platform. I'll talk about NOQA platform in the next segment. Yes, as you probably have heard, Rotary created with the support of the Federal Ministry of Health what we call the NOQA Nigerian Obstetric Quality Assurance, which is an electronic platform which allows death audits, death and perinatal audits. When a child or a mother dies, all the details is in the system, and anyone can access it. Each hospital has a subcommittee to consider a monthly consideration of all the maternal or perinatal deaths within that hospital, and to know why such a mother or a child died. The beauty of the system is that no one is blamed for doing anything, because if you start blaming people, people start to deny things. So whenever the committee meets and they find what the problem is, it's also stated on the platform why the person died, and another hospital can access that platform and see why the woman died, and such as the can apply that in his hospital. And that system is the maternal perinatal death surveillance and response. It allows death to be recorded, and there is the response to be also recorded. So each death has its causes and what has been done by each of the hospital, and every hospital can access it. But the good thing is that it also goes to the Federal Ministry of Health in Abuja. So the Federal Ministry of Health can actually monitor what is going on in all the primary and tertiary institutions in Nigeria. As at the moment, it's only the government hospitals, but in the future, we are going to add the private hospital. So private hospital will also have access to the maternal and perinatal death surveillance and response. So it's now it's a data management. There's no paper. You can, at the press of the button, decide what happened in Bagada General Hospital, and it will print out how many mothers have babies, how many died, what was the cause of the death. In fact, it also gives the history of the mother, how many children he had before, all the other details that is required for a doctor or for another hospital to take advantage if such a case happens in that place. So we've done away with paper, but we have taken a major step in this MPDSR in the Nigerian, well, it's now called National Obstetric Quality Assurance. And the major step is that we have now, it's now a law. The National Assembly has passed a law to make MPDSR a law in Nigeria. So every hospital eventually will have to link up with MPDSR. The only thing we are waiting for is for the president to assent to the law, so that the MPDSR will become law, and there are penalties and all that. It's a big voluminous thing, but still it has penalties and what all that is required. So we hope before Buhari leaves office, he will assent to the MPDSR law, and it will become law that binds the survival of mothers and children in Nigeria. I thank you very much.
Thank you, PDG Nijiraji. We are very grateful for your presentation. Like I keep saying, most of this presentation will be left on the Club Finance platform and the President's platform as well, so that you can look at it and probably allow people to discuss with you, with your group, with your club at some point in time, especially some of the medical aspect. We are grateful for the engineer coordinator to be able to dabble into the medicine and present it very well. But sometimes we might need more questions that people in the medical line will be able to explain to you. Things like what's up? Obstetric hemorrhage, eclampsia, and need for cesarean section and sepsis. These are the things that we actually need to know a lot about, and it's very 1 minute to convince you to be a good advocate in some of these presentations. So now that you have spoken, I only hope you take the slide seriously and you study it and for your own progress in your own club. Thank you very much. Now we send the next 5-10 minutes for PDG Professor Yomi Adewuki to now explain further the practical details of this successful project, which I'm very proud of. Thank you very much, Bakada.
This governor fellow Rotary, my chairman, PDG, has given details of the activities of our action group. But it's important for us to note that the intervention of Rotary in this area of maternal diet started in Nigeria in 1994. And there is a national coordinator, Professor Lufadi, who has been involved in this program in 1994. At the level of, and what are the interventions? Interventions are mainly in 4 areas: data management, and that's what PDG talked about, the MPDSR, quality of process, quality of infrastructure, and quality of care. And you find out that these 4 areas are the main areas of intervention that Rotary has been involved in since 1994. And a lot has been achieved as my chairman said earlier, he talked about the fact that as at now, there's legislation which has already been passed. And that legislation is one of the ways of obtaining the various interventions that Rotary has been involved in 1994. In area of quality of process, several hospitals have been upgraded, especially the health center. You find out that when the project started, it was restricted to about 4 local governments in the Kaduna state. Today, 34 states have been covered by the electronic platform in area of data management. Particularly in our own district, in 2019, we started projects on reduction of maternal and child health. And that project lasted for 2 years, 2019 to 2021. And it was aimed at reducing the average maternal death from 560 deaths to about 400. Professor Pichu, who is an obstetric professor in Kaduna, assisted a lot in gathering data in this area. And we expected that because the project started, stopped last year, was completed last year, but still expecting what are the outcome of that particular program. Our own project basically in the area of quality of process, and that is training, capacity building of the various medical officers in the various hospitals. It also involved quality of care, helping babies breathe. Various doctors, nurses were trained on how to help babies breathe in the 3 states where the project took place. That is Oyo, Ogun, and Lagos. And 15 hospitals were affected, were selected for this program. In all, nearly 2 years, we trained over 1,713 doctors, nurses, and medical record officers. We held over 1,000 community dialogues in the 3 states in over 100 communities within the 2 years. This covered about 1 million population in the three states of Lagos, Ogun, and your states. And we also ensure that in those 3 states, data were gathered. Major consultant was Professor Fabawu, and we ensure that data were gathered, and new data that Professor Chichu currently analyzed, and hope by the end of this year, the data will come out to know how far the project has succeeded in meeting or in reducing the maternal and child health. So that's the we intend to upgrade the program, because we found out that malaria and malnutrition also are important elements in ensuring that mothers have healthy babies, and mothers also, a healthy mother will normally bring forth a healthy baby. So nutrition finds a major problem in our local community. So the upgrading is going to affect about 495 health centers in 3 states of Lagos, Ogun, and Oyo. And we believe that if the mothers are made healthier, then we'll get more results than currently have. So as at now, we are trying to upgrade the project. And we must say that the project is under the auspices of our action group, the maternal action group for maternal and child health in all over international, in Rotary International. So these are some of the things we have done and we will continue doing to ensure that health of our mother is very improved, and then reduction will be able to achieve in ensuring that our mother give birth early babies and children are also healthy. Thank you.
Thank you very much. Now, listening to this presentation will make you feel proud about the activities of Rotary in maternal and child health. For those of you looking for slides, Professor Yomi Adewumi too will make a presentation that will be available on the platform of club trainers and the imaginative president. So the floor is now open in the next 20 minutes for questions and answers. So you can raise up your hand if you want to ask some questions. Thank you very much.
Next one,
Adeton, the floor is yours. Adeton, unmute yourself.
Thank you very much.
Yeah.
Good morning, my PDGs, my highly respected Rotarians. I want to thank you for the great job you have been doing. I used to be a member of your committee, but I ran away for some time. So, my contribution, I'm very glad about all the achievements, all the plans, the goals. But my contribution is that we cannot divorce adolescent health from maternal and child health. This is because the adolescents dovetail into becoming our future mothers. So we must find a way to address adolescent health as soon as possible, to include it in our program. And then, of course, we need to engage the men because they cause part of some of the delays. There are communities where the wife cannot go to hospital even in labor unless the father approves. And also the contraception you have mentioned, family planning, we need to engage the men and make them more relevant in this issue of our maternal and child health. And then, of course, we talked about hemorrhage. So I'm glad that Rotarians are encouraging blood donation. We need to support blood donation so that the men do not think that they have to look for touts if their wives are in labor and have issues of hemorrhage. Then also our religious and healing homes. They contribute a lot to these issues, especially the delays. This issue of it's not my portion. I'm going to my pastor. I'm going to my alpha. We need to educate them to know when to refer. We don't say don't go there, but they must know when to refer to so that we don't lose our mothers. The other issue is something that is out of our hands, which is human resources for health. Yes, we are training, we are engaging them, but a lot of them are doing jackpot these days. So this will be engaging government because we cannot do the employment for them. But we need to engage government to look into the areas where we prevent our trained personnel from human resources for health from doing this japa, I don't know if it's japa or japa, to other communities. Thank you very much. That's my contribution.
Thank you, Adeton. My PDG Nijiraji, over to you.
Yes, thank you very much. You know, part of the maternal and child health is the creation of youth adolescent centers where young people, we normally would train teachers who will train young people about when they get to puberty, the precautions they need to take. In fact, our club has applied for Global Grant twice, but we have not been successful to create youth adolescent centers in Yaba, where the young people can go there. They have sports, but they also have clinic and a training room where people can talk to them about contraceptives, about getting pregnant, and they also have somebody who they confide in in the center. So that's a key part of the maternal and child adult youth adult centers. But unfortunately, and I think Lagos State University has one, but I haven't had the opportunity to visit them. But that's one way that we think we must go to also ensure that the young people also come up to know what they need to do as young adults to prevent unwanted pregnancies and all the rest of it. Secondly, fathers in maternal and child health is key. Each time we have a community dialogue, we try to invite the fathers, and before a woman gets a contraceptive, whichever one, whether reversible or non-reversible, even ordinary condom or whatever, the husband must approve. Women in our society are very dependent on their husbands, so some husbands are tyrants. You cannot do it unless approved. So we encourage men to accompany their wives to the council session, because the family provider also will counsel the woman, also decide what type of contraceptive is best for her in the presence of her husband. So her husband knows what problems is likely to happen, because there are a lot of myths about contraception. Some say they take some contraceptives or medication, they get fatter, or they all sorts of things. So when their husbands are there, they also share in the pain or whatever of the woman. So we encourage men to be with their wives when they go and do the contraception at the family providers' hospitals. Thank
you very much. Chinedu, the floor is yours. Chinedu, unmute yourself, please.
Yeah. Thank you so much, sir. Thank you so much. My club, Rotary Club of Victoria Island East, have been very, very, very keen on child and maternal health, and we have been trying unsuccessfully to do a global grant on it. In fact, we pride ourselves of having brought the contact of the AMPA group to this when we did a pilot program on helping mothers survive, which we did with the primary health department of the Lagos State Ministry of Health. And it was quite a very successful pilot project. And I shared it also with the district trainer, Dr. Motoshaw, on how we can go about it. I'm glad that this morning, a lot of my club members are on because we need education. So my question is, how can the group help clubs like ours that have interest in furthering the aims and goals of the Rotary in this area, so that we can be more, we'll be able to do as we plan. So I'm just looking on what directions we can get and how we can have a closer interface and training and help in helping clubs like mine do bigger and bolder projects in this regard. Thank you so much.
Thank you, Chinedu. I'm quite aware of your problems, and I promise from now, I probably will give it impetus. So for a start, try to get in touch with Yomi Adewumi from Rotary Club of Bagada, or you can invite him to come and give you a talk, so that one-on-one you can really make that a progress. The chairman of the present project we are describing is away in diaspora, so that when he comes, he can join the conversation. But for now, you can, at your convenience, before this is April, before you run away to Australia, you arrange for Yomi Adewumi to come and have a talk in your club. Thank you very much. So that
sorry, even when it's in Australia, usually RMCH has a booth. You can meet Hannah or Daniela at the booth, Peter, and because we have RMCH all over the world. I mean, our last project, we had support from Korea. The district in Korea supported us. The club Hanseon in Korea supported our group. So if you look for help, just go to the booth, and but before you get there, write up what you really want to do and ask for help. Or you get in touch with national coordinator, Professor Olufadeju in Ibadan, and I'm sure he will be willing to help you. As you probably are aware, Nigeria won a $2 million program of scale last year, and we are just starting to implement that program. So Nigeria is very strong, and because we have strong partners from Germany, so I don't think that you have problem getting a global grant.
Thank you very much. Chinedu, you don't have to harass me anymore. So you're going to get your problem solved. Thank you. Rotary Naibe, the floor is yours.
Thank you. Yes. Thank you, my PDGs. Thank you, the district trainers. My question, and this is Rotarian Ote Naibe of the Rotary Club of Falomo. I'm actually the incoming president. My question is on the slide on maternal and perinatal death audit. What caught my fancy was on the digital electronic data management system, which is actually currently within the federal hospitals. So I have two questions. Are these integrations also currently being shared by the states in the federation, or what states is part of these integrations? And particularly the private hospitals that are so many, some are small, some are big, which will soon be integrated. Are the private hospitals aware of this system? And how can Rotarian clubs be part of the role of this integration? Thank you, sir.
Thank you.
Yes, all the 36 states, including Abuja, all the government hospitals within the 36 states and Abuja are hooked up to this MPDSR platform, the NOQA platform. You can Google it. You can go NOQA, NOQA network ng.com. You can see what the network provides. But as answering your questions, the private hospitals are not connected at the moment, but that's the next stage of the assignment of connecting all private hospitals in Nigeria.
Thank you. Rotarian Omololu, you omit yourself and ask your questions.
Good morning, everybody.
Good morning.
Good morning.
Yeah, my name is Rotarian Dr. Tomi Omololu. I'm from Rotary Club of Maryland. Beautiful presentation by the presenters. My question is on at the level of intervention of quality of care and process by Rotary Club, by Rotary. So I would like to ask concerning obstetric hemorrhage, as a club or has Rotary ever been involved or thought of the provision of anti-shock garments to prevent obstetric hemorrhage, or the training of medical personnel in using it? Because since it reduces the severity of hemorrhage before the patient is being transported from community health centers or PHCs to tertiary institutions. Is this something we are considering, or you've ever considered, or are there any limitations to us considering them? Thank you very much.
I cannot say for sure that that is being done, because we know that there are a lot of references from primary health centers to secondary centers, even to tertiary institutions. In fact, what we have noted is that sometimes a patient is far from a secondary center to a teaching hospital, but they didn't have a report back. What happened to that patient? What did they do to it? And that's part of the failings in the system, which is now being rectified. But not being a medical personnel, I wouldn't be able to answer that particular question about the hemorrhage and how it's treated. I know the way we've done is, if there's a hemorrhage, depends on whether it's a placentation or not clotting. The medical doctors know exactly what to do. And if there are tear, they know what to do. They stitch it up, and but besides that, I cannot answer the question. I hope I will go for another 6-year medical training, and then I'll come back and answer your question.
Thank you very much, my chair. Actually, you've done most of the question. But earlier on, Thomas talked about people donating. In this situation, most of the blood transfusion that can take place can only take place in the secondary medical care.
Yes.
There's this that could be done in primary health care centers. But prompt referral and knowledge by the primary health center can help alleviate the situation. As a Rotarian in your club, the time you get more involved, you think you take part in participating in most of these Rotarians who have connection with blood donation center. Ikoyi has that type of facilities. So if you are from Rotary Club of Maryland, if you date with Rotary Club of Ikoyi, occasionally when you have a situation like that, you can encourage some of your people to participate. So once you are a regular donor there, you have a way, you are a stakeholder, you can talk to people in accessing blood from Lagos Blood Transfusion Service. Thank you. Any other questions? Raise up your hand. It's still about 5 more minutes to go. If there are questions, you can still entertain that. On the other hand, you can actually send your question to the Rotary Center, and they will try to get in touch with you. Unmute yourself and pass your comments.
Yes, thank you very much. I listened to the issue raised by Dr. Omololu. I think what we need to do is to reach out to our local governments, maybe the state primary health care boards in the states we are operating. When I was in service, these anti-shock garments were provided, and the local government personnel were trained so that they can use it while transporting the clients to the secondary level of care. What I don't know is if it is still being sustained, or it might be a good project for the committee chair to consider. But then you have to find out what is on ground and how we can support. It's a very good to use the anti-shock garment to transport the bleeding clients to the next level of care. We might have to look at that. Thank you very much.
Thank you, Adito. So I hope Omodolu will take that up, and it's from a very good club and very efficient in making a project work. Thank you very much. Again, like I said, we may not be able to answer all the questions now, but if you have something that's very important to your club or to you, you can send your message to the district and we'll get back to you. Again, once again, thank you for waking up early in time to join us. And this might necessarily be the last edition. Initially, we were thinking that one edition will come up early in May, but a lot of changes has happened. The Lagos state government, federal government, they are trying to do census for the first Saturday. This has necessitated the district to change their district conference to the second Saturday. And by third Saturday, we are preparing to go to Australia. So I hope next year we continue the same program. Thank you very much and God bless. You can now go and join your party for today. Thank you very much.
Thank you. Everybody should join RMCH.
My brother,
so much, sir.
Now go and sleep.
Our trainers, thank you so much, sir.
Thank you.
And all the panelists.
Thank you.
Thanks.
Thank you, PDG.
Thank you,
Thank you. Thank you all.
Lovely.
Thank you very
Bye.
much.
Thank you.
We love
Thank
you
so
all.
much, sir. God bless you.
My Wale Ubadejo, just to let
Thank
you
you,
know that I
sir.
recognize your presence. Thank you for joining us. Wale, thank you. All right, good night. Good morning. No, some of us are going good night.